but she's been right in the middle of the reel. So I'm very interested to hear her speak. So Tammy, if you want to take it away.
Hello, everybody. Happy afternoon. I am so thrilled to be presenting today. We have really been listening to an amazing group of speakers, and I want to thank all of them for presenting. The information that they've been presenting is so important, and for long-term care, we need to hear it. We've needed to hear it for years. I think we've been hearing it, but then we have different things thrown at our heads, and we have to deal with it. So I am pleased to be here. I do need to tell you I have no disclosures to report. I also want to thank Dr. Mahajan and Dr. LaRocca for their wonderful words of wisdom for long-term care. Actually, if I could have come through this computer and just hugged them, I would have done that. I so enjoyed the information you shared. I feel like I have been speaking your words for literally years, and I'm hoping everybody's listening. And yes, Lisa and Nell are the best, so I agree with you there. Today, I'm going to talk a little bit more about antibiotic stewardship, but even more than that, because without the basic principles of infection prevention and control and having a really good, strong program, our infections are going to increase. And we are going to treat those infections and possibly some of those potential infections, and our antibiotic utilization is also going to increase. So our job is prevention, and all of the things that I'm going to tell you today help you kind of put a big bow on this prevention so that we can actually improve our antimicrobial stewardship. So just a little history. In 2009, we had to look at what we were doing for infection prevention in our company, and we created an infection prevention control manual that was totally based on the CMS guidelines. In 2010, we started adding infection preventionists to all of our skilled facilities. And I tell you, all of you know how difficult that is. You know, we have so many nurses running around that have no jobs that we are just plugging them in and plugging them in. Well, that is not the case in long-term care. It's difficult to get nurses right now, and now we really need skilled nurses that are infection preventionists. So it makes it even a little bit more difficult. In the beginning, when we first started adding those infection preventionists, many of them were also the director of nursing or the ADON, and sometimes they still are in some of the smaller facilities. That's a very tough job for a director of nursing, and I know Deb has said time and time again, we need to do something about getting our IPs full-time or part-time, or figure out exactly how we're going to handle that in long-term care facilities, and we're going to talk about that in a little bit. In many of the larger facilities, there is a designated IP, but sometimes, even today, they still wear many other hats. And here are just a few of the hats that they wear. We wear, as infection preventionists, we wear a police hat because we have to be rule followers. We have to wear a hard hat to protect our already hard heads. I'm telling you, I know you guys, and you do have hard heads. Mine is one of the hardest. A fireman's hat because we put out a lot of fires, and we prevent a lot of fires as well. Sometimes we put on a Viking hat, and that is we are warriors. We are strong. We have to be warriors. A football helmet, because sometimes you just have to take one for the team. How many of you have done that? A joker's hat, because seriously, there are times that you just need to laugh. A magic hat, because they frequently expect us to create magic. And there are times when we actually do that, and it amazes me every time, but it does happen. A party hat to celebrate our victories, and a witch's hat, well, that's just because. So it is your job as a facility team to decide how many hats are really truly appropriate for each person. And I think if you look in your facility right now, you will see people that are drowning because they are wearing too many hats. So what can you do about that? Well, one of the things that we need to do is keep our communication lines open. In-house, definitely. We need to allow that daily report, that the morning meetings that we have to keep everyone on the team updated in what is going on with infection prevention and control. We also need to keep our communications lines open with other providers. So the hospitals, are your IPs familiar with the IPs from the hospital? Are they communicating? Are they having some kind of a conversation with each other? Are we being transparent with hospitals and asking them to be transparent with us regarding infections? What kind of infections are you actually getting from those hospitals? Are you communicating whenever you get a C.diff and the C.diff came from the hospital? Make sure that you're doing that. Make sure that you have a line of communication that is fully open and nobody is upset about it. They're talking about it. You're solving problems together. We need to have a good communication with our lab partners. Have you even talked to your laboratory? What kind of a relationship do you have with your lab? Are you getting reports from your lab on a regular basis? Are you asking questions about the report that they're sending you? Is there an antibiogram attached to it? Is there some way that you can ask for more information, more data? Can you sit down there with them and try to figure out what you really need as a facility to make sure that you are looking at these infections appropriately? What about your pharmacy provider? I know all of you have a pharmacy provider. Are they a part of your QA? Are they a part of your day-to-day? Can you pick up the phone and call them and say, hey, I just want to talk to you about this antibiotic that we have that we're giving. Just want to make sure we're on task with this. Are those people available to you? You need to be able to have a conversation and communication open with them. We need to remember that communication is a two-way process. It includes all the leadership. So all of your leadership people, and you are one of the leaders in your building as an IP. The administrators, the director of nursing, your department head team, you're all leaders and people are going to be following you. The physicians in your facility, hospital partners, lab providers, pharmacists. You need to observe, back to observe. We need to make rounds to make sure in the building that you see what's going on. How many of the people that you work with, your physicians, your lab providers, your pharmacists, your physicians, how many of them, maybe even some of your hospitalists, come into your building and actually are invited in your building, know what's going on in your building, are familiar with long-term care? Part of our job is to educate everybody about what we do and how we do it, because we really do it very well. So show off a little bit. We need to listen, truly listen. What are the issues and how can we assist each other? My sister always told me I actually needed less mouth and more ears. I have a tendency to talk more than I do listen, and I want to try to get better at that. So it's a goal of mine. But my two ears just go a little bit crazy sometimes, and sometimes they shut down because my mouth overloads them. So just so you know, we're all in this together. We need to listen to each other. And if we're not listening, stop and say, please listen to me. I need to tell you this. Be supportive. There are consequences if someone on the floor, actually, this is hidden from me, doesn't wash their hands. So they've got a nurse and she's all shackled up here. Are we actually supportive of our staff? Are we supportive of not just our staff in our building, but are we supportive with all of the people that come into our building? Do we make them welcome? We help them understand? Do we answer their questions? We need to make sure that we are doing that. Infectionists, preventionists have a very tough job, just like everyone else in long-term care today. I am not dissing anybody because we are all having tough times right now. But we need to provide suggestions when opportunities arise, and we really, really need to support change because change is coming, change is here. And I really do not know any group that does better with change than long-term care. You guys, you are amazing. You take it and you run with it and you make the changes and you make a difference. You are caring for a very vulnerable population and you're doing it in a great way, and I couldn't be prouder to work with all of you. We need to provide nourishment to all of our team. So there are certificates that are available. Of course, CMS has required all IPs to receive that training in infection prevention and control. We also have the 3-hour and 4-hour training that's required for our staff and our physicians. Please make sure that you're doing that. The surveyors are coming in and they're asking for it now. If you have one person that has not been trained and it's out of the time frame, you could get a citation, and you probably will because they've been given the direction to do that. So please make sure you have a system in place so that you're getting that training done right in the very beginning when you get a brand new hire and all of your other people already have it done. The 19.3-hour course that is provided by the CDC, and there's also a 42.5-hour course that was an APIC course. So you can take either one of those or both of those. They are very informative. They give you a lot of information about what's going on with long-term care and about infections, about antibiotic stewardship, all kinds of information. And there are others as well, and they're coming. There are more coming. There's a lot of education and learning opportunities through APIC and through some other groups too, like webinars. The webinars that we attend on Fridays, those are great. Deb and Karen do a wonderful job with those. Very proud of those two gals. They are really, they have a lot of stuff going on. So we do attend webinars and services. Do have fun with your education. Keep it kind of interesting. Use flashcards if you need to. Make some pretty posters. We have actually a poster contest every year on hand hygiene. Our company does. And it's really, we give money. We give money for the prizes, and we get first through fourth place. And everybody can do it. And we get some really cool posters. It's very neat to be able to do. Right now, we've been doing a lot of phone conferences, and I know those get really tough, and I really miss people's faces. I really do. But right now, we've still got to do that. So there are times we can be together and times that we cannot. Use your good judgment and make sure you're doing it appropriately. Okay, so in 2011, I joined APIC CI. That is APIC Central Illinois. And I'm just making a plug for APIC right now because we, as long-term care facility IPs, have got to speak up. We have got to have a voice. We are not well represented at all. And we need APIC as bad as they need us. We need to show them what we do. We are proud of what we do. If we do not speak up now, we're going to be left in the dust, and we can't really afford to do that. So I encourage you to join an APIC chapter, whichever is closest to you, and get your voice. Have your voice heard. This is a flyer that I actually sent out to the APIC Central Illinois, all of the facilities in Central Illinois that we would be potentially pulling from. And if you received this, we have been trying to make phone calls, but it's very hard. I know everybody is so busy. Left messages, and my name and my number is right down there with my email. If you would like to join APIC, get a hold of me. We'll figure something out. Like I said, we want you and we need you. Here is the way that you can just click on this and you can join, and you're going to be receiving all this information. Okay, so other things. Are reports complete? Are your numbers of infections improving in your facility? Are trends being addressed? Are goals being met and revised? Do you have a quality board to show off your successes? You really need to have something because your staff needs to know where they're at, where you expect them to go. Otherwise, they have no purpose for those numbers. So you have to provide numbers for them. Are the IPs receiving the education they need to be successful? How are we keeping infections at a minimum to reduce antibiotic use? Are you monitoring cleaning and disinfecting processes? You have to be doing that. Does nursing work closely with EVS, environmental services, to make sure the facility sparkles and shines? Our facilities should all be sparkling and shining, and I'm not sure that I think that the floors should. Those create a little issue with residents that have difficulty seeing, but we do need to make sure the facility is clean at all times. Hand hygiene is not just the responsibility of infection preventionists. We all play a part. Something that I have been encouraging at our buildings is every Monday, every department head, first of all the department heads know how to do hand hygiene. We make sure that we competency them. And then every Monday, every department head takes a resident and an employee, and they have the entire week, and they can do hand hygiene with them numerous different places, many, many times. They can talk to them about it. They can show them. They can return demonstrate. That whole week, they have 2 people that they're focusing on. Make sure that those 2 people know how to wash their hands, how to provide hand hygiene with ABHRs. That's their goal. That's one of their goals. So it doesn't fall all on the IP's shoulders. It's a great way and for everybody to learn how to do it and make sure we're doing it clearly. In a facility that I heard about, we had a little resident that was very, very short, very, very small, could not actually get up to the sink. And whenever they were doing that, they found that out and figured out a way to get her hands washed the way that she needed to wash her hands. So there are successes out there just for those things. We need to know our residents and see what we can do with them to make them safer. Clean hands save lives. I always have to tell you something about hand hygiene. I use so much alcohol-based hand sanitizer, my hands had to join a 12-step program. I really think that a lot of people think that I drink, and I really don't. But I think I am in a 12-step program for hand hygiene because I wash my hands all the time, all the time. Hand washing. This is one of my favorite because C. diff tastes even worse than it smells. I love that. Oh my gosh, how true is that? Okay, some more ideas. Surveillance. Surveillance is important. Surveillance needs to be a team approach. It is not something that one person can do. We all need to do it. We have a part in it. We educate people on what we're looking for and how we're looking for it, and we find all kinds of good things. We find some bad things too, and that's okay. That's what we're supposed to be doing. We find the issues. We need to open our eyes and we open our ears and open our minds and think about what somebody's telling us. Many times you will walk by a hole in the wall that has been there for a long time and we quit seeing it. But that new person that walks by that hole in the wall comes back to us and says, "Oh my gosh, you have a hole in the wall." And all of a sudden that hole is back and we see it and we need to deal with it. So let's not put those blinders on. Let's make sure that we're opening our minds so that whenever somebody does see something that's a little different than what we're seeing, we can evaluate it, look at it, not criticize, but try to figure out how we need to fix it. Another thing, are you meeting burdened? I mean, yes, burdened. We have so many meetings. Can you put them together somehow? So if you're having IP meetings at the very end of your daily morning meeting or your weekly morning meeting, however you put that together in your building, can you have a little quick 5-minute something on infection control? What we need to talk about, how we need to go about doing something this week, um, whatever the hot topics happen to be. Do a little education. Send that education out with your department heads to their departments, making sure they're educating their people. It's really important that we don't spend tons of time talking about it if we're not spending any time doing it. So just know that. I'm big on putting meetings together. So here are the must-haves for your infection prevention and control program. You must have an infection prevention control program that is reviewed at least annually. I'm like, blah, blah, blah. A way to update your manual as rules or guidelines change. You have to be able to update. You have to be looking at it, and it's constant. You have to have an active infection prevention and control committee. Do you actually have a committee in your building? If you don't, you better have one, and your medical director needs to be a part of it, at least. You may have other physicians that want to sit in on it, but you need to make sure that you are touching bases with all of those people. You need to have a plan to continually educate your staff, your residents, and even visitors on infection control principles. Can you put things up? Can you posters? Anything that can help you educate somebody. One of the things that we do in our company, we have an antibiotic fact sheet. We have all of these wonderful daughters and sons that tell us whenever mother has a urinary tract infection. She starts getting a little confused, so we need to start an antibiotic. And sometimes they even call the doctor to get the order for it, and the doctor calls it into the nurse that hasn't even assessed the resident. Has that ever happened to any of you? I think the story is yes, it has. So what we did is we created an antibiotic fact sheet whenever we have some of those people, and they are wonderful people, but they don't know the new information. They don't know that we don't just throw antibiotics at people whenever they have a sniffle. Influenza is a virus. We don't treat an antibiotic. We don't treat a virus with an antibiotic. There are many pieces of that. So we put antibiotic fact sheets out. We put them in the admission packets and give them out. We also have them at our nurses' stations. So if people do have questions, we can hand them this and say, here's some information you might be interested in. So that's a good thing to do. Make sure that we're continually doing those types of things. Our policies have to be consistent with current best practice. We also have to have an active surveillance program. We talked about that a little bit ago. Once again, surveillance is just not one person. The ability to track and trend infections. You have to be able to look at those. You have to look at having a communicable disease reporting protocol because it's policy. And you have to have a policy for outbreaks and investigating outbreaks. You also have to have a person that has access to the XDRO registry. I know that can be a little bit of a pain, but if you click on this link, it will give you directions on how to get in there. That person, the XDRO registry it's of two purposes. The first purpose is to query for new residents. So if you're getting somebody in, you can look and see if they have an infection that could be problematic. It's also a way that you can use to report an infection that is new so that other people know that we have an infection that's out there. A person, more than one is a great idea, has to be reporting now to NHSN. That is only going to get bigger. We're going to be reporting more information to NHSN all the time. We've started doing it slowly, but I'm telling you, it's going to be massive reporting before you know it. We have to have an employee health plan because we protect our employees as well. If we don't protect our employees, our residents are not protected. If you think about it that way, it's an easier way to think. We have to have an annual TB facility risk assessment and an active vaccination plan for our residents and our employees. Now we have to have an active respiratory protection program. I know that is very difficult in our buildings, but we have to do it. It's not going away. It's something that we're doing today, we're doing tomorrow, and we're doing the next day. So figure out how you need to do it. Many of us have already started. Make phone calls. We will help you any way we can to make sure that your program is working and it goes by the guidance. You need to have a water management plan and a committee. Legionella, there are other diseases out there that are also waterborne bugs that you need to be prepared for. There has to be COVID-19 oversight and a plan for EVS and nursing to provide cleaning and disinfecting to protect everyone. We actually use something in our company that we call it the Pen Light program. We have people that go out and they mark areas that are supposed to be cleaned before they are cleaned. Then when somebody goes in and cleans them, we check them again to see if they were cleaned, and it's an opportunity for education. We want to make sure that everybody's aware that we're doing it and it's being done constantly so that everybody's on task, and nobody wants to do it wrong. Everybody wants to do it right. And if I happen to miss a doorknob, I need to know that because that might be something that I'm just not focusing on. If I need to focus on it, you need to tell me about it. You have to have an antibiotic stewardship protocol, monitoring the use of antibiotics, written antibiotic protocols on antibiotic prescribing practices, and documentation of indications, dose, and durations. Every single antimicrobial that you give should be reviewed. One of the things that I actually developed is we have a log that is for our true infections. We use the McGear criteria and we log our true infections, but every single antibiotic is listed on an antibiotic sheet. We ask a series of questions regarding those antibiotics as to when were they started, were they started before, were they started after admission, how are we tracking those that we're getting from the emergency room? So we talked about that. I think somebody said something about that earlier about sending somebody out to the ER and they get an antibiotic. You may need to go out and meet with the ER physicians, just like I think one of the doctors said something about this earlier. Go out and meet with the ER physicians. Let them know what we're dealing with. It may be even important that we put something on their transfer sheet that says does not meet definition of urinary tract infection. Asymptomatic of urinary tract infection, whatever you need to do to make sure that they are aware of what's going on. We had a bad situation not too long ago that we sent a resident out that was having minor stroke symptoms in the very beginning, but we know our residents, they are our family members. So whenever that they're not talking very clearly and they've always talked clearly and they're starting to have difficulty gripping, we immediately know something's going on. Sent them out to the emergency room. They came right back like boom with a urinary tract infection. When the EMT started to get them off the stretcher, they could not move. They could not get off the stretcher because their right side was totally flaccid. They took them back to the emergency room and they were diagnosed with a stroke. I think part of this is we have got to be communicating with the ERs. We have got to be telling them what we're sending them and why. Our assessment is really, really crucial. So what ended up happening is that person was on an antibiotic that she didn't really even need. And they continued that. They sent her to another hospital. They treated her with that antibiotic through the full course of antibiotics. She never really had a urinary tract infection. So there was an unnecessary antibiotic that was given, and the real problem was a stroke. I know that doesn't happen all the time, but our job is to try to combat that from happening ever. When we're looking at utilization of antimicrobials, we also need to look at document days of therapy, obviously, adverse reactions to anything. It's really important that we list the name of the physician that's doing the prescribing so that we can look at it and we can go back and say, okay, Dr. Dodo is ordering all of these cultures, and they don't actually meet the criteria for infection. It may be really important to sit down and talk with this doctor to find out exactly what's going on and have a conversation. Maybe we're missing something and we need to know what's happening. Our physicians are wonderful. They treat us very well. They are very good with our residents, but things change, and we need to be in touch with them as much as they need to be in touch with us. So we must follow the CDC core elements of antibiotic stewardship for nursing homes. It's listed. You can find it anywhere. You should have a policy that actually talks about all of those. So the leadership role, it asks for actually a written statement from leadership supporting antibiotic use. And so you need to make sure that you are getting all of that. If you just go through that listing, it will tell you exactly what you need, and you can write your protocol just based on that. Accountability. So who's on your team and who's actually accountable for this? Every single person. We start with the very beginning. So when we are looking at somebody that has a potential infection, it doesn't start with the doctor. It starts with it could be the housekeeper that's going into the resident's bathroom to clean the bathroom, and they notice that there's a change in the color of the resident's urine. It's normally just clear, and boy, it looks really dark right now. So is that resident drinking? Are they hydrated well enough? And I think hydration came up in one of the other meetings. We need to make sure our residents are hydrated. Do we have a hydration program in place? Have a little bit of fun with it. One of the things that we did is we put some big we call them hydration stations, and they're big containers, and we fill them with water, but we put different flavors in them. And we don't put sugar or anything like that, but we flavor them with things like lemon or lime or strawberries. How about cucumbers? I mean, they're really refreshing. And if we can get our residents to drink those, that makes a huge difference. Sometimes it's just a matter of talking about it and say, look what's floating in the water today. It's a cucumber. How about you try this and see what you think? Well, people are intrigued, so you can get them to drink more if you get them intrigued. You might be surprised at how it works. So accountability, everybody's accountable. Drug expertise. Do you have somebody in your building that has drug expertise? Or do you have a pharmacist that you can rely on or pick up the phone and call and say, hey, I need some information. We're getting an order for this, and I'm not familiar with the drug, or what do we need to do about this? How can you help me? So drug expertise is really important. Action, I believe one of the meetings that we had earlier this morning was very specifically on action. What are we going to be doing about that? Are we documenting our infections? Are we documenting the antibiotics? Are we isolating appropriately? Are we using our risk management tools to make sure that we are administering antibiotics appropriately? Tracking. Are we tracking and trending infections? How are we looking at them? Are we getting our pharmacist involved about the tracking and trending and saying, what do we have in this area? Are we using a facility layout and highlighting it so that we can see if we have infections that are in certain places? Are they really true infections? Are we causing a problem that is increasing our antibiotic use because somebody's not washing their hands or somebody's not doing pericare appropriately? Are any of those things happening? And if they are, we need to be acting on that. That's extremely important that we get that going. Reporting. So we need to be looking at what we have, and we need to be providing feedback to people. So feedback, one of the regulations says that we have to make sure that our professional staff are aware of what's going on with our infections. Are you posting something? Are you letting people know? Are you looking at the physician specifically and saying, this is what your tracking is for antibiotic usage in our building? How are you doing that? Are you using antibiograms? I know in most of our buildings we have such a low number that that's very hard to do. But if you will work with your lab, or some of your hospitals have antibiograms, they can help you with that, and perhaps that can help you to see what is going on in your area or in your part of the state. Education is the last one, and that can never stop. We have educational opportunities everywhere. We need to keep educating our people, make sure that they know what's going on, what we're doing, and what we expect of them. And you know something, it's just not a matter of educating, it's a matter of following up with them and saying, Okay, now we showed you this, or we taught you this. Now we want to see it in action. So is it happening? Are the things that we taught you how to do, are they really being done? Or are they not? And if they're not, then we need to have another conversation. It might be a little tougher conversation. So is leadership on board? This support is one of the core elements. Our antibiotic usage patterns, sorry, that's a misprint, monitored on a regular basis. Are we able to obtain antibiograms from admitting hospitals? We already talked about that. And do you have a drug expert? Antibiotic use risk management tools should include the evaluating and communicating of signs and symptoms of potential infections. So you're logging those potential infections, or are you logging just true infections? If you're totally missing the potential of infections, you're going to be in trouble. So you need to make sure that you're looking at it from the very beginning, you're assessing, you're evaluating, you're making a determination. So if you do have that person that their urine is darker, what do you need to do about it? Well, there's the hydration program that you put in place. But you need to make sure that your physician is aware of what's going on, because there's a change in this resident. Maybe they're confused and they're forgetting to drink, and that's really the issue, and that's great, and that's fine, and you fixed it. Maybe it's something more than that, and you can't let your guard down, and you can't just think, okay, that's what it is, and we're not going to worry about it anymore. You also have to look at those residents that you turn over in bed and they're coughing. That CNA needs to be reporting that to the nurse and say, I've not noticed John Doe coughing, and he's been coughing whenever I've been turning him. Well, the nurse needs to go down, put a stethoscope in her ears, listen to those lungs, see what is going on with this person. It's all about the resident. Remember that. We need to optimize the use of diagnostic testing, following physician's orders, of course. So if we really think something's going on, we're calling, we're assessing, we're giving the physician the information that we've got by evaluating that resident, and we're getting orders to get a chest x-ray or do a UA or whatever it happens to be that's going to follow up with that. Then are we giving appropriate antibiotics? That's something that is very, very key. And I am really big on, you have got to look at that sensitivity. If a culture was done and we are giving an antibiotic and we never look at the sensitivity, we just missed a whole big piece of what we're supposed to be doing for antibiotic stewardship. If you get somebody that is, for instance, they go to the ER and they give them an antibiotic for urinary tract infection. You get the culture back and there is no growth. It is imperative that you call the physician and let them know that, so that we can get that discontinued. If you're not getting them discontinued, you may need to get your medical director involved to have a conversation, or somebody, maybe your expert on antibiotic utilization, to be able to say, this is what we really need to do with this. Whenever there's no growth, we shouldn't really be treating it. So make sure you're communicating those things. Are culture and lab findings available to you easily? I know that some buildings have difficulty getting that information, so you might have to go and have a conversation with the lab or with whoever's doing your x-rays, making sure that you're getting them timely so you can make a decision. I know we talked about, antibiotic timeouts. We need to make sure that we're utilizing that. So we also need to monitor for adverse drug events. So if we're giving an antibiotic and the antibiotic is not necessary, that could be a problem. Even if the antibiotic is necessary, sometimes people have adverse effects from them. So we need to make sure that we're monitoring that and staying on top of it. We have to collect and review data. Every piece of the infection control has got to be monitored closely. So when we're giving the antibiotic, is it the right antibiotic? Are we giving it the right time? Are we giving the right dosage? Are we giving the right route? Are all of those things in place? Are we doing it the right way for the person? Do they truly have an infection? You have to review the data. You have to continually review the data. Once the person is no longer symptomatic, what are you doing about that? Are you just saying, well, we're going to go ahead and give the next 5 days of antibiotics? Are you picking up the phone and calling the doctor and saying, okay, these were the symptoms. We had a culture that came back. It was positive. This is what we did. We gave the antibiotic. This person is feeling great. They're drinking. Their urine looks great. They're no longer having the symptoms that they had prior to. Doctor, what do you want us to do with this? And possibly getting orders to discontinue that antibiotic a little bit earlier. And that goes with reporting and providing feedback. Also making sure that our physicians and our professional staff are aware of what we have going on in the building at all times. Education for staff, residents, family, and visitors. I can go over this over and over and over again. It's all the same kind of thing. We are now reporting some data in HSN. More stuff is coming, like I said earlier. And of course, I cannot say this enough. We all need to support and be a part of environmental services, and that is our EVS department. EVS is not by themselves. Anybody can pick up a rag and clean. You just need to know what you're cleaning it with, how to do it safely, and make sure that everybody's aware that it got done. So this is just a little joke. As I suspected, you're full of bacteria. We're going to have to throw you away. Uh-oh. Guys, you can do this. You can do this. We are doing this every day, and you are an amazing group. I hope you're all soaking up this information, and please do not worry. We're not going to throw you away. You are a keeper. We appreciate you all. And honestly, I want to personally thank everyone for everything that you do for all the people that you come in contact with every day. I know you're dealing with the residents, you're taking care of the families, you're taking care of the visitors, all of your employees that you're dealing with every single day. You're educating. I know we can't put our arms around them, but there are other ways to do it without actually having the action. So I want you to please take care of yourself. You are special. Happy infection preventing infections, reduce antibiotic use. So thank you very much for having me.
Thank you so much for that very heartfelt and really informative presentation. So if anybody wants to put information in the chat, go ahead and do it. I've got a question. I queued one up, sort of my own, because I'd love to hear your perspective on this. Can you speak to how and if, because this is developing in long-term care. In acute care, it's pretty mature, the whole concept of the electronic health record and managing data. And because acute care tends to have the lab and the pharmacy and the staff that are taking care of the person and the patient in the same building, it makes it much easier, generally on the same system. But you're streamline your data collection, to improve your real-time surveillance, and how, if you've had any experience that's been successful blending the electronic health record with the pharmacy data, the lab data, and then that frontline interdisciplinary team daily report to help with outbreak identification and antimicrobial stewardship.
Well, that was saying a lot, Deb. You just said a mouthful. And actually, it is kind of a big deal. We are actually looking at 2 programs right now that we started with Infection Watch, and we've been doing Infection Watch for a while and realized that there were some things that were missing, and started working with them and building that platform to make it more user friendly. But now point click care and other users are actually coming up with infection data that is pulling directly from the EMR, from the medical record, and it's much easier to use. There are some little things that need to be fixed in those, but I encourage you to go to whoever your EMR provider is and ask them if they have any kind of an infection program that you can look at, and have them show you exactly how it flows, so you can make a determination on what you actually need in your building. Like I said, we're reviewing Point Click Cares right now, and there are some very good things about it. 2 years ago, it was not ready for us, and they are building on it and doing really a great job. Like I said, Infection Watch is also out there, and it does a great job for those of you that are familiar with that. And there's more to come. So just make sure that you're focusing on that and asking questions. So
That's great. And then we have another question. It's a comment, but it's a very important one, that, they're going through their SBAR steps and they're making sure that their hospitalizations, when they send somebody out, it's appropriate, but they're still getting people back with a diagnosis of UTI, probably
absolutely.
with an antibiotic. And, they're saying that that's really challenged. And it would be really interesting to hear if you've had any really successful approaches on that. I mean, I can give one that was pretty good, but if,
I tell you, it is interesting. And this is what I find, and I'm not dissing anybody at all, but I am a nurse, And I talk really, really well with nurses. I actually can talk really well with physicians too. But physicians really, if you're criticizing in any way, they need to talk to another physician. That's really the best way to do that. We have gotten our medical director involved, and he has gone in with me, and we have sat down and talked to people before. That is really very successful. That is, I mean, I have went to a hospital before and we had a little bit of success, but it was a temporary success because they had ER physicians that they were pulling from other places. They weren't not their staff. So it was very hard to kind of continue that process. Um, but you have to talk to those doctors. Somebody has got to go in and have a conversation and let them know. I know that the ERs have very specific regulatory things that they are doing, and they are looking at urines with everybody that comes in from long-term care. So I really did appreciate the physician that was talking about whenever he was talking to the doctors that were not ER doctors, but just regular physicians that thought that it was okay to just give antibiotics for everything. So we really need to continue to educate, and I think you guys can do some of that, and I think you've been doing some of that. So if you need help with anything, please reach out. I know, Deb, if you've got a story to tell, that would be great. We do need to continue to do that, and get your medical director involved if you can. Meet with them, have a take some tea or take some crumpets or something if you feel like you can.
I had the fortune of having a really good relationship with our medical director, and what we found when we did some interviewing with the other physicians and the nurse practitioners is that the person would come back from the ER with an antibiotic. Sometimes there was some concern about DCing it when it had been written, to your point exactly, Tammy. And so it was a situation where making sure that the prescribers were more comfortable with the concept of stopping an antibiotic, even if it had been started in the ED and hadn't been, except for urologists, if it was, or excuse me, except if it was an infectious disease physician. If it was an infectious disease physician, that was one thing. The other one is, you don't want auto stops on a catheter that a urologist spent half an hour putting in. I've had that happen too. So, it's like you have to, but to your point exactly, you've got to get that whole team together and selectively think about what's happening with this particular person. And they have gotten a lot better, not just automatically throwing antibiotics, but it can be prescriber dependent too. So
Well, I tell you,
communication.
here's another thing that's really important. If you are a part of APIC, any APIC chapter, many of those chapters have a lot of your IPs for your hospitals. So actually have a conversation with them. See what the best way is to interject your information and meet them in a positive manner. So I know somebody had put in, sometimes it's an intern that prescribes an antibiotic, and you're
And
right. I mean,
and
it's all
and
over the
it's
board.
that time of year. It's
Yes.
that July 1st time where, you've got your medical students that just became interns. And
Yeah.
so that can have challenges too.
Yeah, it is. It's not always fun, but I know you guys can do this, and I know you need to open your mind as well and bring information to them in a positive light. It's not about criticizing, it's about protecting our residents and making sure that they are safe. So if you need to take an article on not treating asymptomatic bacteriuria, then you need to do that. I mean, sometimes they respond to that. You need to figure out exactly what they need, and you might do that through that IP. So there's an open door right there. That would be great. Good questions, everybody. I
Yeah,
appreciate the comments too. Thank you all very much.
really good questions and comments. Let's see. The PowerPoints will be released, so you will get them. Um, let's see. I'm trying to see if there's anything else. We've got another 15 minutes.
I know. I know. I talked really fast. I'm sorry. I was
Yeah, no, you did good.
do like here's another thing that I have also done in our buildings. I put together it's an infection prevention control facility review. And I ask other people to do it because I want other eyes on it. I want other people to look at it and see. And it includes many, many things. It includes a lot of things about watching people do dressing changes. It includes looking at the logs. Are the logs up to date? Are staff transporting linens appropriately? Do they have appropriate PPE at all times? Where are the PPE? Does everybody know where it is? Asking them questions about the disinfectants in their buildings. What are you using for a disinfectant? How does it work? And what is the kill time on it? That's really important. So do they know what that means? They need to know what that means. Is our hand hygiene practices in place? Like I said, I'm a really big hand hygiene nut. So um, do you have processes in place for your committee? Is your committee active, or is it just kind of a so-so? Do you have notes? Are they taking that information to QA? Because that's coming to QA. Um, Here's another thing that you might just be interested in, and I know most of you probably already know this, but there are some proposed changes to the Illinois Register. I looked at those uh, maybe 3 weeks ago, and I made some recommendations because I didn't think the changes were really appropriate in some ways. But if you look at the Illinois Register, what they're trying to change under Subpart A, and these are the sections, it's 300.340, and that is incorporated reference material. There's a lot of stuff in there that's really hospital based. Then there is section 300.650, that's personnel policies, and 300.696, infection prevention and control. You really need to read that because that's very interesting, some of the things that they've listed there. And the last one is 300.697, and that is about your infection preventionist. They are making recommendations for them being at least 20 hours a week. If that is the case, it's not going to be easy for a DON to be the IP if they're required 20 hours a week, because in the regulations, they've got to work 36 hours in a week. So you can't really do that. So you're going to have to figure out what you're going to do with an IP. This is kind of like, I think Deb said this earlier. In the very beginning, when we were looking at MDS people, we were on, okay, this is MDS, here we've got to go and we've got to move forward with this. Well, we're doing the same thing with IPs right now. So eventually, we need what we need in our building, and you need to be looking at your infection tracking and your previous tracking to see what you think you do need to cover that. They've got to be on
Yeah,
top of it.
definitely. And as most of you probably have your IPs also helping with OC Health, respiratory protection programs are not going to go away. With this OSHA emergency temporary standard, it's probably not going to necessarily be so temporary with pieces of it because of, people have died related to COVID. And the thing that Tammy, I haven't talked to you about but the thing that I realized when I was going through doing research for stuff, I didn't realize that we were supposed to be wearing N95s if we were doing aerosol generating procedures for influenza, and that's been for a long time. Read totally over it.
Yeah.
And so that isn't going to go away. NHSN is not going to go away. And you're going to probably find that it would be my suggestion, and you guys have heard me say this before, that any of the voluntary modules, you get up and going with those. So, because my guess is they're not going to be temporary, or they're not going to be voluntary very much longer. For NHSN, and they're going to start using that. The advantage to this is if once we get enough people, and they're getting it, once they get enough data in there, it's sort of like the antibiogram that Tammy was saying. Because you don't get a lot of data, it's hard because you just don't have a lot of data points. Now that they have a lot of data points into NHSN long-term care, they're going to start being able to compare your building to like buildings, so you can benchmark off of NHSN. It's what the hospitals do. And it's not just a matter of just dumping that information in there. There will be data that you can use down the road, which should be helpful. And there are two other questions. Do you have an audit sheet that you're using?
I have all kinds of audit sheets. What are you needing an audit sheet for? I guess that is what you need to tell me.
Okay, Rebecca, put more in yours, and then we'll go to Natasha's. What's a good platform for education for staff?
Oh my goodness, we do all kinds of wonderful things with staff. I've been known to do some really crazy things with staff, but how do you think your people learn? One of the things that we use a Relias program, and it is great. We can track it. We can look and see exactly what we're dealing with. It is a program that it's computer based, and we have a whole list of things that before you ever hit the floor, you have to go through all of these things. It is a very, very good opportunity for education. So you might check into that if you don't already have that. But you can't just let somebody get on a computer and read the information and take the test and think that they know what they're doing. So there are competencies involved. You have got to make sure that you are watching them, you are teaching them, you are doing the right thing, so they are watching you and seeing that it's the right thing being done. I'm going to follow your lead because you are the leader. So if you're a leader and you're not ever washing your hands, you're probably going to have a lot of followers who are not going to be washing their hands. So um, it's important that you think outside the box just a little bit. And I know people don't like that verbiage anymore, but I personally like it. Um, you have to think about how your people learn best. And sometimes they learn by doing, sometimes they learn by seeing. I put posters up, I do flashcards, anything that I think I can do to get them to learn. We were having some issues with cleaning, and so we had a little webinar, or not a webinar, but we had a bunch of people in a room, and one the EVS person and myself were doing this, and we came in as thing one and thing two. We were dressed as thing one and thing two. People still go, oh my gosh, I remember when you guys ran in there, and Dr. Maurer, who's our medical director, was the cat in the hat. So people respond to stuff like that. You've just got to think, how can we get them to start thinking this direction and do something even a little crazy, and they will remember it and they will do it.
Excellent point. Rebecca clarified, you said audit sheet for monitoring logs and other things you just talked about.
I actually, Rebecca, do they have my email address? I mean, how can they send me something? I can send them something back.
Do you want to
You know?
just put it in the chat?
Okay, let me see if I can do that. I don't even know if
Or
they'll.
I can, you know what? Or I can do it because I bet I have your heritageofcare.com, right?
Yeah, it's. Wait a minute. I think I can do it. Let me see.
Okay. Okay. If you can't, I've got your email.
I'm just sending it. See if it comes through. Yeah,
Yay!
actually, you reach out to me and I'll send you what I've got. It will not be today. I can tell you that, but it will be soon. How do you like that?
That's good. There it is.
If
Okay.
anybody has any questions, if there's something I can send you that I think can help you, or anything that you think you can send me that can help me, we share. So that's great. Okay. Is there anything else?
And I'll do one more shameless plug for ABIC. That's where I meet people like Tammy and Karen and everybody else and Dr. Mahajan and are the professional organizations. And it's really refreshing, especially if you're the infection preventionist, to go and meet a bunch of people whose eyes don't glaze over when you start talking about infection prevention and control. So, and it's a great place for sharing and learning a lot of things. So thank you so much, Tammy. This has been wonderful. This is amazing. If
Thank you all for everything you guys do every day. I'm amazed by the work that you all do. So very proud to be working with every one of you. Stay strong.
Yes, thanks so much, you guys. I think
Okay.
I think we can stop.
I, I, I think there's something at the very end, like a Q&A at the very end of the meeting. It's
Yeah,
from 4:40.
don't leave until you fill out whatever evaluation you need to fill out. Don't
Yeah,
leave.
yeah. Make
Don't
sure that
leave.
you do that. So just click on the next link, and it should be ready in about 5 minutes, I would say.
Okay, thanks so
Thank
much,
you all.
guys.
Okay, bye-bye.
Thanks. Bye-bye.